Nutrition and nutraceutical supplements for managing hypertension. Hypertension is a major issue in the United States, and many of our patients are seeking ways to lower their blood pressure without taking medications. So in this program, we're going to talk about first, what are the issues with hypertension in the U.S.? What are appropriate blood pressure goals for patients in various groups? Then we'll talk about what are some of the nutritional things people can do and the various supplements that are effective for lowering blood pressure. As we go along, we'll be incorporating some of this information into a patient case. As you can see on this next slide, hypertension is an issue in the United States. Almost 30% of adults in the U.S. have high blood pressure. Similar rates among men and women. As you can see, the prevalence increases as we age, reaching 65% of those 60 and over. So a lot of people in the U.S. have hypertension, but do we do a good job of controlling their blood pressure? Well, not great. Of the people who are identified and treated, 52% have their blood pressure controlled to goal. Now, we all know the consequences of hypertension, and those are just summarized here on the graphic on the right side. That's the point of treating high blood pressure, is to prevent these complications. The next slide lists blood pressure goals for various groups of patients. But before we talk about goals, we also need to define what is hypertension. Earlier this year, the Joint National Committee published the 8th version of the hypertension guidelines. In those guidelines, they no longer define what is normal blood pressure or hypertension. So I have used here the guidelines from JNC 7 because they really still apply. I mean, we consider a normal blood pressure to be less than 120 over 80 millimeters of mercury. Pre-hypertension is 120 over 80 to 140 over 90. So someone is on their way to developing hypertension and needs an intervention, not usually medication, but probably lifestyle changes. Hypertension are values greater than 140 over 90, and either value can be high. Both don't have to be high to be considered hypertension. In the new JNC 8 guidelines, they suggest treating the general population greater than 60 years old who has hypertension to a goal blood pressure of less than 150 over 90. That's a little bit of a change from JNC 7, less aggressive. For the general population less than 60, the goal's less than 140 over 90. And you can see that for diabetes and chronic kidney disease, if patients have those in addition to hypertension, we also have the similar goals of 140 over 90. The 140 over 90 for people with diabetes is a little different from the American Diabetes Association guideline goals, so just so you're aware of that. Leslie is the patient we'll talk about as we go along during this program. She's 48 years old. She started treatment for hypertension 6 months ago. She's currently treated with an ACE inhibitor. She approaches you in the pharmacy with multiple supplement bottles and asks which you would recommend for her hypertension. She's got garlic and Coenzyme Q10, fish oil, and magnesium. Her doctor wants to add another agent because her blood pressure's not controlled on one agent. Many people are going to require more than one medication to control their blood pressure to goal. As a matter of fact, the majority do. Before we can talk about her, I'd like to know what her blood pressure is so we can see how much lowering she needs to get to goal. We checked Leslie's blood pressure today and it's 146 over 94. She's taking enalapril 10 milligrams a day and she's been taking that for about 6 months. She has no other known conditions and she's not on any other medications. She does exercise frequently. So what is her blood pressure goal? Well, she's 48, so she's under 60, but she has no other known conditions. Thus, by JNC 8, her blood pressure goal is less than 140 over 90. So based on today's readings, she needs about a 6 millimeter of mercury decrease in her systolic blood pressure and 4 in her diastolic. So can she reach that goal with nutrition or nutraceutical supplements? Keep in mind her 6 millimeter decrease as we talk about the various options that are out there. To answer the question of whether Leslie can reach her goal with nutrition or other non-drug interventions, let's first talk about dietary and other lifestyle interventions for lowering blood pressure. The table on the next slide summarizes the lifestyle recommendations from the American Heart Association and the American College of Cardiology guidelines on reducing cardiovascular risk. These are the guidelines that the JNC 8 guidelines specify for lifestyle modifications for lowering blood pressure. This table includes approximate systolic blood pressure reduction for each intervention. Usually you see a smaller reduction in diastolic pressure with each of these. Also, the A or B after some of the modifications is the rating of how much science backs up the recommendation. So you can see that weight reduction leads to a lowering of blood pressure if someone can maintain a normal body weight. The amount of blood pressure lowering you get with weight reduction does vary by how much weight someone loses, and they have to keep that weight off. We're going to talk more about the DASH eating plan and dietary sodium. Physical activity can lower blood pressure 4 to 9 millimeters of mercury. Moderating one's alcohol, you get 2 to 4 by reducing alcohol intake if it's been excessive. So you can see from this table, there are many different lifestyle modifications that can help people, like in Leslie's case, augment their medications to lower their blood pressure to goal. Or in the case of someone with pre-hypertension, they may be able to get their values down to a number that's no longer considered pre-hypertension. But the important thing about lifestyle modifications, and hopefully I'll emphasize this on several other things, is you have to keep this up. It's not like you can lose 10 pounds, lower your blood pressure, and your hypertension goes away. You've got to keep that weight off. You've got to keep going with dietary sodium restriction or keep going with physical activity. It's not a one and done thing. It's a lifetime thing. DASH diet is one dietary way of lowering blood pressure, and it's the Dietary Approaches to Stop Hypertension diet. This diet's very similar to the Mediterranean diet and also the American Heart Association Step 1 and Step 2 diets. It's high in vegetables, fruits, low-fat dairy, whole grains, poultry, fish, and nuts, low in sweets, sugar-sweetened beverages, and red meats, low in saturated fat, total fat, and cholesterol, rich in potassium, magnesium, and calcium, as well as protein and fiber. The big thing about DASH is it's a low-sodium diet. DASH 1 is a 2.4 gram per day sodium diet, and that lowers blood pressure about 10 millimeters of mercury systolic and about 5 for diastolic. DASH 2 is a 1.5 gram per day sodium diet. And one's a little tough for people to adhere to. You've got to be very religious about your sodium, looking for sodium in foods. And DASH 2 lowers blood pressure a little bit more than DASH 1 because you're lowering sodium a little more. The website given here is a great 64-page book on how to adopt DASH. It includes meal plans and recipes. DASH can be used in addition to medications. It works very well with almost all medications. It's also a reasonable diet approach if someone also has hyperlipidemia because it lowers saturated fat, total fat, and cholesterol. This next slide shows you some sodium facts from the United States. As you can see from this, we all need between 150 and 500 milligrams of sodium intake a day for good health. The recommended adequate intake level is 1,500 milligrams a day. The tolerable upper intake level is recommended at 2.3 grams per day. But notice how much sodium we typically take in. The average daily sodium intake for people in the U.S. over the age of 2 is 3.4 grams a day. So by and large, the majority of us take in too much sodium. The dietary guidelines for Americans recommends for people who are 51 or older, African American, have hypertension, have diabetes, or have chronic kidney disease, that they only take in 1.4 grams of sodium a day. For everyone else, the guidelines recommend 2.3 grams per day. Now, 1,500 milligrams a day of sodium is pretty tough to live with. The American Heart Association, American College of Cardiology guidelines for reducing cardiovascular risk, their guidelines recognize that reducing sodium intake can be tough. So they recommend reducing dietary sodium intake to 2.4 grams of sodium a day, or at least reducing by 1 gram a day. There is data to show there's benefits of at least reducing by 1 gram a day in reducing cardiovascular risk and in reducing blood pressure. So even if people can't get all the way down to 1.5 grams a day, they can at least bring their average of 3 to 4 grams a day down to 2 to 3 grams a day. How can we help our patients reduce their sodium intake? What's to help them recognize where they get their majority of sodium each day? From naturally occurring sources, that's only about 12% of our intake. Salting our food at the table is 6%. Adding salt when cooking is 5%. But the big hunk for most people is through processed and restaurant foods. So if people can learn to recognize sources of large sodium intake in the processed foods they buy and in the restaurant foods they typically eat. You'll notice here I've listed the top 5 sources of sodium from restaurant foods in prepared sandwiches, pizzas, burgers, chicken entrees, and Mexican entrees. Another source is through Chinese food. People can make better choices by reading labels and reading menus and looking for low sodium products. They can learn to reduce their sodium intake. Now, there's also a lot going on through food manufacturers in slowly decreasing the amount of salt in products so that as a population, we're forced to reduce our sodium intake. Another dietary approach is just increasing one's potassium intake. Some studies find that taking a potassium supplement or using potassium chloride salt substitute can modestly lower blood pressure. The recommended potassium intake is 4.7 grams per day. And the big thing about keeping blood pressure in check is to have a potassium to sodium ratio of 4 to 5 to 1. So we should be consuming much more potassium than we consume sodium. Fortunately, that's not the way we usually do it in the U.S. On average, Americans take in 1.7 grams per day of potassium with a 1 to 2 ratio. So if patients are looking to lower their blood pressure, they can either reduce their sodium intake, increase their potassium intake, do both, or go as far as to do the DASH diet. Supplementing one's potassium up to that 4.7 grams per day recommended intake modestly decreases blood pressure 4 to 8 millimeters of mercury for your systolic, depending on how much you supplement the potassium. Somebody actually did a meta-analysis and plotted it out, and you can find that for lowering systolic blood pressure 1 millimeter of mercury and half of a millimeter for diastolic, you have to take in 0.6 grams per day of additional dietary potassium. Adding extra potassium to one's diet appears to be most effective in people who have a low potassium intake or high sodium intake or are African American. I mean, it does work in other people, but you get the most out of it in those groups. It doesn't have to be done with potassium chloride salt substitutes or potassium supplements. It can be done with food sources. And just a couple that you don't always think of that I wanted to highlight here. A sweet potato has 694 milligrams of potassium in it. Beans are a very great source, so are prunes. We all think about bananas and orange juice, but actually they're much lower down on the list in the amount of potassium per serving. We do have to keep in mind that some patients with hypertension do need to avoid getting extra potassium. Patients with renal insufficiency or who are taking potassium-sparing diuretics, ACE inhibitors, or angiotensin receptor blockers have an increased risk of hyperkalemia, particularly when you combine things like renal insufficiency and an ACE inhibitor or potassium-sparing diuretic. You can get in trouble with hyperkalemia. One other component of the DASH diet that is high is magnesium. People have also tried lowering blood pressure just with magnesium supplements. Competes with sodium for binding sites on vascular smooth muscle and acts as a direct vasodilator like a calcium channel blocker. Supplemental magnesium can lower systolic blood pressure a median of 5.6 millimeters of mercury. Something I haven't said before, but when I'm talking about how much one of these interventions can lower blood pressure, it's a median value from studies. There are people who get more out of it, there are people who get less out of it. That's just sort of, think of it as the average you will probably get with an individual intervention. Increasing magnesium is additive to high potassium, low sodium intake. That's why it works great in the DASH diet. It also improves the efficacy of antihypertensive medications, so they work better. Food sources, dark leafy greens, nuts and seeds, beans and lentils, and whole grains are just some of the top sources of magnesium. Again, we have to be cautious in patients with renal insufficiency because they can't eliminate excess magnesium efficiently. As we've gone over, people can significantly lower their blood pressure with dietary interventions and other lifestyle changes such as exercise and weight loss. There are also several nutraceutical supplements that can be used, so we'll now spend a little time talking about those. Complementary and alternative medicine use in managing blood pressure is relatively common. Many patients use a lot of things like relaxation techniques, biofeedback, acupuncture, tai chi, etc. to help lower their blood pressure. There's not a tremendous amount of information out there about nutraceutical supplement use. I could only find one survey that really focused on this. In it, 27% of the patients surveyed used some kind of an herbal for managing cardiovascular risk. Didn't specifically ask about for hypertension. 68% used some vitamin or mineral. The most common things that people said that they used for hypertension were CoQ10, fish oil, and garlic. And we'll talk about each of those. As you can see from the table on this next slide, there are a lot of so-called natural antihypertensives out there. It's way beyond what I can cover in 1 hour to talk about all of these. So I'm going to focus on the ones that are most commonly used. This table actually comes from a fascinating 3-part series in the Journal of Clinical Hypertension on the underlying pathophysiology of hypertension and how nutrition and supplements work as natural antihypertensives. So I give you the reference here, and they're available free online through pubmed.org. So you can easily get them and read them. They're very interesting. If you're interested in learning more about the underlying mechanism of how all these things might work. Before we begin talking about the individual supplements, I wanted to review the efficacy rating system I report for each agent discussed if it's available. Based on scientific evidence, Natural Medicine's database rates various supplements. They use a rating system from effective to possibly ineffective. And they also rate each product on safety. Now, I don't really focus too much on what their safety rating is because I really only cover things that are considered likely safe or possibly safe. One of the supplements to highlight is Pomegranate. For hypertension, some research actually shows that pomegranate reduces the activity of angiotensin-converting enzyme by about 36%, and it's actually additive with ACE inhibitor medications. You can see there have been several studies with pomegranate. One example one is they gave about 1.7 ounces per day of a pomegranate concentrate and saw a 5% reduction in systolic blood pressure at 2 weeks and a 12% at 1 year. 150 mLs per day of pomegranate juice reduced systolic blood pressure about 7%, diastolic 6% with a single dose. They had them drink 150 mLs of juice and check their blood pressure for several hours afterwards and saw that much of a reduction after a single dose. Another study that gave it a little longer term was 330 mLs per day, a modest decrease in systolic blood pressure of a mean of 3 and a mean of 2 on the diastolic blood pressure at 4 weeks. Pomegranate is rated insufficient evidence by Natural Medicine's database. That's because there are fairly small studies and there was the one study that was out to a year, but most of the other studies have only been out to about 4 weeks. Well, if someone's interested in trying pomegranate, whether juice or supplement or concentrate, we have to think, are there any possible problems with doing that? There have been a few case reports of allergic reactions like you see with ACE inhibitor medications, including angioedema, so swelling of the face, tongue, throat. It's pretty rare. Honestly, never encountered a case of it, but there are cases in the literature. Pomegranate juice, very much like grapefruit juice, does have some drug interactions. In vitro, in test tube models, it inhibits CYP2D6, the liver 2D6, and gastrointestinal 2C9 and 3A4. At this point, studies in humans have not seen significant 3A4 interactions. Those are really the only ones that have been studied in humans. What I would recommend to patients with pomegranate juice is, if they're taking other medications, to watch for adverse effects with those medications and not consume excess amounts of pomegranate. Because when we're talking about a dose for blood pressure, we're talking about 2 ounces of a concentrate per day or 8 ounces per day of 100% juice. The dose on extracts and capsules is really hard to put it to what is the equivalent of 8 ounces of pomegranate juice. The other consideration in incorporating particularly pomegranate juice into one's diet for lowering blood pressure is the calories that come with that. It's about 150 calories in an 8-ounce serving. Many people will find they have to mix the juice or the concentrate with other things to make it palatable. Omega-3 fatty acids get touted for a lot of things, but did you know they can actually lower blood pressure modestly? It appears that they lead to some vasodilation. There have been a ton of studies that happen to have looked at blood pressure effects when people were given omega-3 fatty acids supplements. One meta-analysis that looked at 31 of those studies found the overall median decrease in systolic blood pressure was 3 millimeters of mercury and 1.5 for diastolic, compared to placebo. That was in hypertensive, hypercholesterolemic, cardiovascular disease, and diabetic populations. In patients who did not have hypertension, you didn't really see any efficacy. So if someone doesn't have hypertension, omega-3 fatty acids don't seem to lower their blood pressure. Another meta-analysis that looked at 90 studies found that a median dose of 3.7 grams per day decreased systolic blood pressure 2 millimeters of mercury and 1.6 for diastolic blood pressure. Now that doesn't seem like a whole lot, and the median values are not a whole lot. Some of the studies saw decreases up to about 16 millimeters of mercury for systolic blood pressure. It does seem that blood pressure effects are greater in those who are older than 45, and those with hypertension. Like with potassium supplements, there appears to be a dose-response curve for omega-3 fatty acids. One analysis found a 0.66 millimeter of mercury lowering of systolic blood pressure for every gram of omega-3 fatty acids consumed. It seems that if someone takes 2 grams of EPA and 1.4 grams of DHA a day, that you get about a 3 millimeter lowering of mercury on average. Now, that dose can have some antiplatelet effects. Doses of fish oils greater than 3 grams a day can have some antiplatelet effects. So we have to be cautious in combining fish oils with antiplatelet agents or anticoagulants. And this isn't a huge decrease. If someone's taking fish oils for another purpose, such as reducing cardiovascular disease, maintaining their memory, or whatever it might be, they may get some additional benefit in lowering their blood pressure. Coenzyme Q10 is another supplement that gets promoted for a lot of things, but it actually has some pretty significant blood pressure lowering effects. It's rated possibly effective by Natural Medicine's database. It appears to cause some vasodilation, which is probably where its antihypertensive effects comes in. In a meta-analysis of 12 trials, they found that you saw a median decrease of 17 millimeters of mercury for systolic blood pressure and 10 for diastolic without significant adverse effects. Now, importantly, there were only 3 randomized, double-blind, placebo-controlled trials of those. The other trials were open-label trials. The Cochrane group did an analysis of just those 3 randomized trials, pulling them out, and found that you saw an 11 millimeter decrease in systolic blood pressure and a 7 for diastolic. So that's probably because you're comparing it to placebo to see the real effect of the coenzyme Q10. So that's probably what you can expect out of coenzyme Q10 for blood pressure lowering, is about a 10 millimeter mercury decrease in systolic blood pressure. That reduction is actually in line with what you see with antihypertensives. Some studies have also been in people treated with antihypertensives, so the lowering was in addition to background antihypertensives. The dose of coenzyme Q10 for lowering blood pressure is 50 to 100 milligrams twice a day. I suggest people start with the 50 and see what kind of effect on their blood pressure they get. If they need additional lowering, go up to 100 twice a day. Coenzyme Q10 can cause some minor GI adverse effects such as nausea, vomiting, diarrhea. Doesn't seem to occur in a lot of people. The best way to prevent it is to divide up doses greater than 100 milligrams a day. So up to 100 milligrams as a single dose seems to be okay and doesn't seem to cause a lot of GI upset. The only drug interaction of major concern with coenzyme Q10 is warfarin. CoQ10 is chemically similar to mevaquinone, so it has some vitamin K-like procoagulant effects. There have been some case reports of increased INR in people treated with warfarin and coenzyme Q10. One study that looked particularly for an interaction didn't find it, so it's more of a caution to closely monitor patients if they are taking both, and you may need to adjust their warfarin dose. Garlic has long been used for a variety of cardiovascular conditions, especially hyperlipidemia, but there's also interest in using it for hypertension. It is thought to increase nitric oxide production, resulting in smooth muscle relaxation and vasodilation. Multiple trials again, a meta-analysis of 11 studies. Systolic blood pressure decreased median of 8.4 millimeters of mercury, diastolic 7.3. Another meta-analysis that looked at different studies found a decrease of 16 millimeters of mercury for systolic and 9.3 for diastolic compared with placebo in patients with hypertension. So they only looked at patients with hypertension in those particular studies. It is thought that the active component, or at least one of the active components of garlic for lowering blood pressure, is allicin. And allicin is what gives garlic its distinct odor. So the dose for lowering blood pressure is a little difficult to pinpoint because most people try to look at it in terms of allicin content. The dose that's recommended of garlic powder is 200 to 300 milligrams 3 times a day, standardized to a 1.3% allicin content. And allicin's converted to allicin in the body or when exposed to air. There's controversy about whether aged garlic extract is effective or not. Some studies do show that it's effective because when you age garlic, you actually convert all the allicin to other compounds. Aged garlic products should be standardized to S-allyl-L-cysteine content, or sometimes on the label it's only listed as SAC. The dose that's recommended for hypertension of aged garlic extract, 600 milligrams to 7.2 grams per day, divided up in 3 doses. Patients can also use 1 clove per day of fresh garlic, crush it up and eat it. That's probably the most breath unworthy of the methods to lower one's blood pressure, but it can work. Garlic is rated possibly effective by Natural Medicine's database. There are a few things you have to consider about it. Of course, the adverse effects of breath and body odor, mouth and GI burning or irritation, heartburn, flatulence, all those good GI things can occur, particularly when you're talking about these higher doses of garlic. The aged garlic does seem to have cause less mouth odor and body odor, but it may not be quite as effective. There are some significant drug interactions with garlic. Because it has antiplatelet effects, it's best not to combine it with antiplatelet agents or anticoagulation agents. It also appears that allicin induces CYP3A4 metabolism, so there's potential for issues with some medications metabolized by that enzyme. So possible issues with oral contraceptives, saquinavir, isoniazid, cyclosporin are all things that there's potential for interaction. Garlic supplements have been reported to increase both saquinavir and isoniazid metabolism. Hibiscus sabdariffa, which is rated insufficient evidence by Natural Medicine's database, is used in many countries around the world for managing hypertension and hyperlipidemia. It is thought to have properties of both a diuretic and an ACE inhibitor. Been studied in several trials. I highlight 3 of them here. In one trial using 1.25 grams of dried leaves in 8 ounces of water, steeped for 6 minutes 3 times a day, they saw a 7.2 millimeter lowering of systolic blood pressure compared to 1.3 millimeters for placebo, about a 6 millimeter difference. Giving an extract that was standardized to 9.6 milligrams of anthracins once a day was equivalent to captopril 25 milligrams BID for 4 weeks. Now, this was not a blinded study, and it didn't have a placebo group, so people have criticized that study for that. But at least it tells you that it does seem to tell me that there's some efficacy to using a hibiscus extract. Another trial looked at a hibiscus extract of 250 milligrams standardized anthracins once a day, and it was less effective than 10 milligrams a day of lisinopril for 4 weeks. Now, again, that was not a placebo-controlled trial. I think you can say you get some blood pressure lowering with hibiscus, whether it's given as a tea or as an extract. It's probably less effective than prescription ACE inhibitors, but at least it does lower blood pressure some. Hibiscus tea goes by many other names: roselle, sour tea, red tea, or Jamaican sorrel. The dose, the easiest thing for people to take is to brew an 8-ounce cup of tea, let it steep for 6 minutes, and drink it 2 to 3 times a day. The one trial that used tea bags, the first one listed on the previous slide, actually used a Celestial Seasonings hibiscus tea, but I cannot find a Celestial Seasoning product anymore that is only hibiscus leaves. As far as adverse effects, there are no known ones that I can find, none reported from other countries. I did mention this is used in other countries to also lower lipids, and there are studies showing that it can modestly lower LDL cholesterol. As far as drug interactions, not a whole lot's known. One report suggested there might be an issue with doses of hibiscus inhibiting acetaminophen metabolism, but there's never been any follow-up of that or case report problems. An animal study did find that hibiscus inhibited hydrochlorothiazide clearance, so it's probably best at this point to not combine it with hydrochlorothiazide. Article referenced here is a great review of all the science about hibiscus. Let's go back now and think about Leslie, our case, who needed some more additional blood pressure lowering. The table on this slide compares all the different interventions. I included the lifestyle changes, dietary things people could do, the supplements we've talked about, and then what average blood pressure reduction you see with various medications. Now, not all the classes of antihypertensives are here because it's kind of hard to actually find what is the average reduction in blood pressure you get with a particular antihypertensive. And most of this data is as a single first agent. You usually get less when it's as the second agent that's added on. So you can see that ACE inhibitors and angiotensin receptor blockers, you get an 8 to 11 or 8 to 12 millimeter reduction in systolic blood pressure. You get about 8 out of alpha blockers, beta blockers, about 6 out of your diuretics. Now compare that to many of these other interventions. So using, for example, Coenzyme Q10 twice a day might get you the equivalent of adding another prescription agent on for Leslie. But there's also many of these other things that people can do, like reducing their sodium, increasing their physical activity, increasing their potassium intake. The big thing I see about the supplements is they all need to, almost all of them need to be used at least twice a day, maybe 3 times a day. And that can be an issue when adding that on as somebody looking for a once-a-day thing. And the only thing studied once a day at this point has been the pomegranate juice. All right, Leslie's current blood pressure is 146/94. Now, because this is an artificial situation, we're only looking at one blood pressure here. And you would never make a decision or a recommendation just based on one blood pressure. You'd want to know multiple blood pressures and where is she really trending and how much decline does she actually need. It would be great to have some home blood pressure measurements from her or some additional ones that we've done or from her doctor's office, but we only have one. We're going to talk as if we can make a decision based on this one and assume that her other blood pressures are similar. She exercises but does no other lifestyle interventions. Remember, she's taking an enalapril 10 a day. She doesn't appear to be overweight. She limits her salt intake, and she's a non-smoker. Her original question for us was which of the many supplements she had in her hand did we recommend? So she's pulled garlic, Coenzyme Q10, fish oils, or magnesium, and asked us this question. Leslie, of course, could do some other additional lifestyle interventions. She could up her potassium intake, lower her sodium more, etc. But she decided to try the Coenzyme Q10 50 twice a day. We asked her to come back for a blood pressure check at 4 weeks, and her blood pressure then was 138/90. So she's less than 140/90. So we would monitor her over time with that combination of Coenzyme Q10 and enalapril. Seems to be effective for her. There doesn't seem to be any long-term adverse effects with long-term use of Coenzyme Q10. No major issues with drug interactions, particularly for her because she's not really on anything but the enalapril. But you still have to think about those things when recommending things too. A few points to cover for when patients are using nutraceuticals to manage their blood pressure. I suggest they do home blood pressure monitoring. If they're doing these supplements to manage their blood pressure, I really think they need to be checking their blood pressure and seeing what it's actually doing. They can do it once a day, a few times per week, try to check it at the same time. An adequate trial of these various supplements seems to be 4 weeks. It doesn't seem to be that you get more out of something the longer you go. The only study that showed that was a year of pomegranate juice. People did get a little more lowering towards the end of the year than what they had in the first couple weeks. Important thing when talking about managing blood pressure, as I said when we were talking about lifestyle modifications, it's not a one and done. People can't just take these for a few months and it cures their hypertension because you don't cure hypertension. What they have to do is continue to take them. So they have to be adherent and persistent for the long term. So are they willing to accept taking a prescription once a day blood pressure medicine or a natural supplement that they may have to take 3 times a day? So what's going to work for them? If they are already taking prescription medications and start with some either lifestyle changes, significant lifestyle changes, or one of these supplements, their prescription medications may need dosage adjustment. So it's important that they know what the symptoms of hypotension are. If you're talking about an older patient, you especially need to caution them about getting up from the bed or the chair so that they don't have falls if their blood pressure is going down in those cases. The next slide just shows you 3 combination products that are out there that are marketed for blood pressure management, and you can see the list of ingredients in these, and some of them have things that do have some efficacy. But if you've listened to my other programs, you know how I feel about combination products. I really think you need to do a single supplement product and see what kind of an efficacy you get. Because if you take one of these combinations and have an adverse effect, you don't know what caused it. If you get a drug interaction, you don't know which thing caused it. And even if you have efficacy, you don't know what really lowered the blood pressure out of this combination. So it's kind of overkill. Also, if you look at some of these combinations, they don't have enough in them to be effective. For example, the one that's got the laundry list of things in it, it has 60 milligrams of Coenzyme Q10 in the 4 tablets they recommend you take per day with this. So this is a QID product. In those 4 tablets, you're only getting 60 of Coenzyme Q10. Well, it takes what's been studied for efficacy is a total of 100 milligrams a day. So you may not get efficacy out of that. Or maybe somebody could get away with just taking Coenzyme Q10 and not all this other extra stuff. One last point, for your patients who are very into natural medications, you should ask about some other things that they take in case they are causing their hypertension problem. Several supplements such as ephedra, bitter orange, which contains synephrine, Siberian ginseng, and true licorice can all increase blood pressure. So always look for, are they taking other things that is causing their blood pressure to go up, that if you got rid of those, then they may not need an antihypertensive. The bottom line on all this, patients can lower their blood pressure with lifestyle changes, various nutritional changes, and with some supplements. Lifestyle changes really are the most important. That's the thing. If people can do these, they can change their lifetime risk of developing cardiovascular disease. I mean, lowering your blood pressure is a bonus here. So losing weight, exercising, low sodium, high potassium, doing the DASH diet. It requires a significant commitment to do the DASH diet. You can get a lot of mileage out of just focusing on sodium and potassium. Now, none of the supplements are probably substitutes for antihypertensives in people who have significant blood pressure elevations, because we know that prescription antihypertensives taken for the long term reduce morbidity and mortality related to hypertension. The studies are out there that say taking these, keeping your blood pressure lower with them, gives benefits in how healthy you live your life ends up being and whether you continue living. We don't have that information on the supplements. I see them more as additive with someone's antihypertensive therapy, prescription antihypertensive therapies, or in people with pre-hypertension or who need a modest reduction in their blood pressure. And you can add these things in with the lifestyle changes. The most evidence is for Coenzyme Q10, then fish oil and garlic.